Hello, I am Dr. Janice Williams, and in this lecture, we will be discussing viral hepatitis. In this lecture, we will discuss how does the advanced practice clinician assess, evaluate, treat, manage, and educate a patient at risk or who has been diagnosed with hepatitis. We will conclude with a case study to help you hopefully be able to gain even more knowledge on how to apply the information that you have heard and learned. We will start this lecture talking about what are the different types of hepatitis, because the word hepatitis alone just means inflammation of the liver. However, there are diverse types of hepatitis. And so when we think about hepatitis, that inflammation of the liver eventually leads to damaging of the hepatocytes. That damage can be fibrosis, it can be scarring, and even necrosis. The factors that can lead to hepatitis, that inflammation, that damage, that scarring, that necrosis, are multifactorial. Factors such as a virus itself can cause hepatitis, alcohol, the medications a patient may be taking, metabolic defects, and even autoimmune processes. That means the body itself is fighting against itself. In this lecture, we will talk about those different types of hepatitis and how do they present and what would you need to do as a clinician for those patients. So let's start by talking about viral hepatitis. Remember, I mentioned that there were many different factors that can contribute to hepatitis, that damage. When you think about the virus, there are 5 different viruses that may impact the liver and lead to viral hepatitis. Not all viruses lead to chronic disease, and not all of these viruses lead to the need for medication management and treatment. Some do and some don't. We will talk about that further as we go through this lecture. But it's important for you to know that there are 5 different viruses. We label them with the letters A, B, C, D, and E. It's also important to know when you're thinking viral hepatitis that just because someone exposed, they can either have acute or chronic. So not only do you want to know which virus is impacting the liver, you want to know is it acute or chronic. Acute means that they've recently been exposed to that virus. It's been less than 6 months. Whereas chronic means they've had the virus for more than 6 months. Usually if a patient has chronic hepatitis, that may be one you need to either manage, and that could just include just diagnostics, evaluating how the liver is doing, to treatment with medications. We'll talk about what makes the difference. We also want to talk, and I would like to talk and share with you about the different types of presentations or symptoms the patient may present with depending on the virus that is impacting the liver, how long that virus incubates, how it is transmitted, and what diagnostic tests you need. You can see from this chart the 5 different viruses are listed here. The symptoms that occur can be similar. What makes the difference is you're thinking about the incubation periods, how long, and then how are they exposed to it. That's the real big piece here because it makes a difference. As you can see from this chart, hepatitis A usually is ingestion. That means these patients have ingested that virus. Same thing with hepatitis E. When you think about hepatitis B, C, and D, this can be related to perennial, that means blood to blood. Whereas hepatitis B and C now, we now know that they both can be transmitted sexually as well. Okay? So knowing the transmission rate, the mode of transmission is important when you're thinking about hepatitis. However, it is easy to look at a chart and say, okay, the mode of transmission. You as the advanced practice clinician needs to make sure that you're asking the question. That's really going to help you to determine what hepatitis you may want to be looking for. So doing a thorough history taking is important. Now, I would like to move to talk a little bit about hepatitis C specifically. When we think about hepatitis C, we're talking about a disease that is spread either it's blood to blood. We also know that it can be spread sexually. So hepatitis C, the reason we will spend some time on this is because it is the most common hepatitis virus that leads to liver failure, liver cancer, also known as hepatocellular carcinoma or HCC. So we want to, if we can, evaluate these patients for their risk, do the appropriate lab testing, and determine if these patients need treatment or not, because there is treatment available. We also want to evaluate as well for hepatitis B, because there are some patients with hepatitis B, just like hepatitis C, who may have some liver damage. And there's treatment for those patients with hepatitis B as well. We will go into more detail of that later. What I do want you to be cognizant of is risk factors. Knowing when you think about hepatitis B or C, I want you to think about how is it transmitted. So if we say blood to blood, think about activities your patient may participate in that would expose them to someone else's blood. Those things can include things like illicit drug use, being exposed to someone's blood because maybe they had a trauma and you were exposed to their blood that way, and even through sexual contact, because we know during the act of sex there can be some bleeding, and the bleeding can then put another person at risk for that exposure. Because one thing about hepatitis, especially hepatitis C, the amount of blood exposure can be microscopic and a patient can still be infected with it. We also know that patients who have a history of maybe having to do hemodialysis are at increased risk. And children who are born to women who have hepatitis C can be at risk as well. There are many risks, and understanding those risks for the different types of hepatitis exposure and potential for becoming a carrier is going to be important. And then doing the appropriate assessment again. And once you think about a patient, if they have been exposed to any of the viral hepatitis or any hepatitis within any of the categories, is knowing how do you manage that hepatitis. Management of hepatitis is going to be specific to the type of virus or the type of hepatitis a patient may have. Because think about an autoimmune. You won't treat that the same as you would a hepatitis C. So management is going to be focused on the type of hepatitis the patient has. Management should be twofold. It should include both prevention and treatment. Your prevention should have two legs to it. Not only is it the education piece, but if there's a need for vaccinations, you should appropriately recommend vaccinations. The other leg of management is the treatment with medications if necessary, and then also including education. So let's move to specifically talk about hepatitis A for a little bit. Hepatitis A is a virus that is an enveloped RNA virus. We have seen a decline in hepatitis A over the years as a result of vaccinations. These are patients who may present with a risk of being exposed to someone's feces through either food or some other source. So when you're doing your assessment on these patients, you want to make sure you're asking the appropriate questions. Although we have seen a decline in hepatitis A, it's still important to assess your patient and ask questions. Questions that can include things like, where do you work? Do they work in an environment where they're exposed to human feces? And also asking about, have they had any recent travel? Because depending on where you travel to, is there contaminated water or other items? So what would this patient look like who presents to you? There is a percentage of individuals who will be asymptomatic, but then you will also have patients who may present with nausea, vomiting, headaches, fever. These are all very common symptoms. They could be any disease process. So part of your differential should be considering, is this hepatitis A? When you think about patients' symptoms, If you do a physical exam on your patient and you are concerned about hepatomegaly or splenomegaly, these are patients you want to make sure you're checking for hepatitis A for. That evaluation can include things not only collecting the information from your patient, making sure that you do the appropriate lab work to evaluate that patient, and then making sure that you, as you assess your patient, that you are including differentials that may be hepatitis B, hepatitis C, or other differentials, because you don't want to miss a diagnosis on your patient. So what does the diagnostics look like? You do want to include in this, for these patients, any hepatitis patient, is liver function tests. You also want to include specific hepatitis A lab, hepatitis virus labs. If you're thinking it's hepatitis A, you want the lab specific for that. Same thing with the other viruses as well. Okay? Knowing that when you're doing your evaluation or your labs on a patient with hepatitis, you want to check their immunoglobulins M and G. One is going to be elevated with acute infection, and one will maybe elevated with long-term chronic infection. So why do we care? Why do we want to assess these patients at all? Why do we care about hepatitis A? Although a large percentage of these patients can clear this virus on their own, hepatitis A can be a self-limiting disorder for the patient. And it can make the patient feel really bad. So you want to treat the symptoms that they present with, be symptomatic. Remember we said nausea, vomiting, fever. So those are the symptoms you may want to treat. You want to ensure that you reevaluate these patients after about 3 to 6 months to evaluate how their symptoms are. There are immunizations out there. Prevention is a big piece to treating any type of hepatitis. If there is a vaccine that you can provide to these patients to decrease their risk of getting a different virus, you would want to try to do that for that patient. The vaccine for hepatitis A does consist of 2 shots. You get 2 shots. One shot should be 6 months from the original vaccination. Now, I did mention that when you're doing your lab work, you do want to check their immunoglobulins for IgM and IgG. Remember that the IgG is long-term. You see that elevated in chronic infection, where IgM is the temporary. Usually you see that elevated in the acute infection. Now let's transition to the hepatitis B. What do we know about hepatitis B? Over 1 million people in the US are infected with hepatitis B. It is transmitted through the blood. Hepatitis B alone has several different genotypes in it, and that when you have patients who have been exposed to hepatitis B, there are some immunoglobulins that can be given if a patient has an immediate needle stick and may have been exposed to hepatitis B. You can also give it to newborns who have a mother who is positive for hepatitis B. So what are these risk factors? We know that hepatitis B transmitted through the blood, unprotected sex, sharing of needles, accidental needle sticks, and then mother to child. Those are some of the risk factors and ways of exposure. So what does an acute hepatitis B infection look like? These patients, abdominal pain, dark urine, fever, joint pain, loss of appetite, the weakness, the fatigue, very common symptoms that can be many disease processes. But if your patient presents with that, you want to make sure that you're ruling out hepatitis B. Hepatitis B is a virus that there is a percentage of the patients who will get exposed to hepatitis B. Their body will fight the virus off, they will clear that virus, and they will build up protection and they will be fine. There is another percentage of patients who will get exposed to hepatitis B and they're what we call, they have chronic hepatitis. That means it lasts greater than 6 months. What becomes important when you think about these patients is patients with hepatitis B, not all will need treatment. So doing an evaluation to determine does this patient need treatment or not is what becomes important. That will be determined by your blood work. Okay? Understanding how to read this blood work to determine if you need to treat this patient, is it an acute infection or is it a long-term infection? Very important. I would like you to stop this lecture. Take a minute to review this chart. The chart will outline for you and help you gain a better understanding if a patient has chronic hepatitis, acute hepatitis, or if they have a viral load related to their hepatitis. Okay? So take a moment, stop this lecture. Well, welcome back. So now that you understand what labs are to be drawn, let's try to understand if a patient, once you get your labs back, does the patient have hepatitis C or do they not have hepatitis C? On this chart, you will see when you think about the labs you will be drawn. Let's kind of walk through this chart. If you look at the very first section, if everything is negative, they may be susceptible to hepatitis C, they don't have it. This would be a patient you may want to recommend vaccination. Let's look at the second column or the second row. If they have Hep B surface antigen negative, but their core and their antibodies are positive, that would mean that they are immune due to natural infection. That core helps us understand that anti-Hep HBC is telling us this patient was infected somewhere. However, they've built up antibodies now and they're protected. And that HBsG, if you remember from the previous chart, stands for Hep B surface antigen. That is negative. So that's telling you they don't have acute infection. So let's go to the third row. If their antigen, their B core is negative, but their antibody surface is positive, that lets you know they're immune because they were vaccinated. Remember, the surface antibody only, protection, but that protection is from vaccination. Now let's go to the fourth. If they have surface antigen positive, antibody Hep B core positive, the IgM antibody Hep B core positive, but the antibody Hep B negative, that is acute infection because that surface antigen is there, that IgM, which is immediate, is there, that's acute. That means that patient's shed in that virus. They were recently infected. Chronic infection says the surface antigen's positive, the antibody B core is positive, but they don't have any antibodies Hep B core or antibodies Hep B surface. They're chronically infected. That patient, we need to do some further testing. The Hep B surface antigen, Hep B core, and the Hep B surface. If the antigen and the surface are negative, but the core is positive, it could be several possibilities. They could have had the infection and it resolved. It could be a false positive. They can have a low-level chronic, or it could be a resolving acute. This is still a patient that what you will do is continue to manage or monitor that patient. So let's do a knowledge check. What does it mean if you would see these lab results? So if you think about it, if it's an IgG, that means they are immune. Acute infection is IgM, and then no immunity, no benefit for the vaccine, right? That's your antibody HAV IgM and the IgG. So what does this mean? Surface antigen negative, antibody surface negative, and the core is negative. That patient is not infected. They're also not immune. Let's vaccinate this patient. So let's try another one. What does this mean? Great. If you said that this patient was exposed but they're recovering, you are correct. Let's try another one. They have a positive surface antigen, a positive antibody core, HB core, negative IgM, negative HB core, and a negative antibody HB surface. So what does this tell you? This patient has chronic hepatitis B. Perfect, good job. Let's try another one. So we have 3 of the 4. You can read and see what they are. Positive surface antigen, positive IgM, positive core, and a negative antibody hepatitis B surface. This patient has acute infection. More labs, more evaluation. So what are the non-pharmacological management for these patients? Any patient with hepatitis, you want them to avoid alcohol. Remember, alcohol, anything that can impact the liver, you want them to reduce. That would include even medications such as acetaminophen, iron, and things like that that are metabolized in the liver. Precautions when you think about blood, and you want to refer this patient, right? Now we're going to move to transition to talk about hepatitis C. You as a clinician who is seeing a patient with hepatitis C should understand the importance of why we evaluate for hepatitis C. As I mentioned earlier, these patients have a higher risk of cirrhosis of the liver, as well as HCC, hepatocellular carcinoma. It is estimated that over 44,000 individuals have acute hepatitis, and that was back in 2017. What we know is that hepatitis C impacts about 3.9 million people in the US. This is why we, as primary advanced practice clinicians, care about hepatitis C. It is impacting our patients at large rates. Hepatitis C, although it is one virus, there are different strands of that virus. Those strands, or those genotypes is what we call it, is dependent on geographic distribution. So when a patient has hepatitis C, one hepatitis C does not fit every other type. They can have hepatitis C type 1A, 2B, different ones. As you see here in this chart, depending on where the patient resides, that may determine, or where they contracted the virus may determine what type of hepatitis C. It becomes important when we think about treatments for patients. It's not that one type is more aggressive than another. It is based off of treatment and the length of treatment. That is not something you as a primary care may be doing on your own. However, you need to be aware that when a patient is treated for hepatitis C, they must be considered, their genotype must be considered. And so there are recommendations that have been established related to hepatitis C testing. It states that if you are 18 years of older, you should have at least one-time evaluation for hepatitis C. You can read the other recommendations, but at least once, 18 or older, they should be checked for hepatitis C. And then based off of risk factors. If they have risk factors even before then, hepatitis C should be considered. The CDC also has guidelines and recommendations. What we know is individuals who have a history of blood transfusion should be checked, injecting drug use, any child born to a mother with hepatitis C. If they have signs of liver disease, their liver function tests are elevated and you can't determine why, they should be checked for hepatitis C. If they're going to donate blood, they should be checked. And then our baby boomers as well. Patients who test for hepatitis C and are found to be positive, they may need to be referred. If you're not comfortable with doing the evaluation to determine if they need treatment or not, they need to be referred to a specialist for evaluation for the need for treatment. We currently have great treatment options out for patients with hepatitis C. A few years ago, maybe 10 years, 15 years ago, hepatitis C was not a treatable and curable disease. It was not a curable disease, but yet treatable. Now we have medications that can cure patients of hepatitis C. However, unfortunately, it does not provide them protection against future exposure to hepatitis C. So therefore, the education on prevention is very important. So what does it cost to treat a patient with hepatitis C? It can cost up anywhere between 70 to 100 and $200,000 to treat a patient with hepatitis C. It can be costly. However, the treatment regimen has improved remarkably over the years for these patients. Patients can participate in treatment with medications that they can take by mouth. They can take those medications anywhere from 3 to 8 weeks to 3 months and be cured. Okay? But let's talk before we go into the cure of hepatitis C. Let's talk about what does it look like with the progression of hepatitis C. So your patients get exposed to hepatitis C, they have the acute phase. Patients may go through where they clear the virus. Those patients usually don't need treatment. But then you have those patients who they don't totally clear that virus and it becomes a chronic infection. They need to be evaluated for the impact of that hepatitis C on their liver. Not always do patients with hepatitis C have cirrhosis of the liver or necrosis or turn into HCC. A lot of that may depend on your patient's habits. It can depend on what medications they're on and things like that, things that can exacerbate the complications with hepatitis C. So that's why education is very important and collecting a good history. Speaking to your patient once you have done the appropriate lab work to not only evaluate their liver function test, but actually looking at if there's any cirrhosis of the liver. And when we think about cirrhosis, we're talking about the staging. Do they have a normal liver? Do they just have some fibrosis? Do they have scarring or do they have cirrhosis? Knowing that is going to be very important. Usually the progression from normal liver to HCC or cirrhosis of the liver is many, many, many years. Cirrhosis of the liver, if patients take care of themselves, can be prevented even without treatment for medications. So who's at risk? We talked about that already. Those who are at risk of being exposed to someone's blood, right? Those are the people you want to make sure that you're assessing for. You want to make sure you're doing the appropriate lab work to evaluate these patients for the possibility of chronic hepatitis C to determine did they clear this virus on their own or do you need to evaluate to see if they need to be referred for a discussion related to treatment. Regardless of what, education is going to be important. Here is a chart for you to help you identify how to think about hepatitis C and your lab results. If you ran the lab results, which is the hepatitis C antibody test, if it's negative, patient doesn't have hepatitis C, you're good. If it is positive or reactive, you then want to run a HCV RNA or PCR test. That's going to come back giving you what we call a viral load, how much virus is actually in that liver. If it comes back negative, that means that patient does not have hepatitis C. You don't have to worry about treating them. You can just maybe do another test in a couple of months, see if it still, the antibody test comes back reactive. Sometimes if you do a HCV RNA test because your HCV antibody test was positive, but the RNA test is negative, it could be a false positive as well. However, if you do a HCV antibody test, that's that screening test. Remember, because remember your pathophysiology. When does antibodies occur? After exposure, right? It's building up these antibodies to kind of try to protect itself. If that test comes back positive, and then you run your HCV RNA test, and that one comes back positive or reactive, that means there's virus in the blood. That means that patient has hepatitis C and they're going to need further evaluation. That further evaluation will include more labs to really determine the state of the liver, to determine if treatment is necessary, or determine if they need to do other things. you should be referring that patient to a specialist. Again, this chart here just gives you more information on how to interpret these labs. One of the challenges for practitioners is understanding how to interpret not only hepatitis C labs, hepatitis A and B labs. So take a minute, stop this film, and I want you to review this chart and see if you really understand what the lab's results mean, because this is what's going to be very important for you as a clinician. So now that you have reviewed what the labs mean, what do we do with those patients who are hepatitis C positive and you are certain they have hepatitis C? The first thing you want to do is get a complete medical history. Remember to include their social history, their family history, and really get a detailed, even their sexual history, psychiatric history. All of those things is very important. And medical history, understanding what other disease processes they have. So detailed medical history. Labs and imaging are going to be important. The labs you can see are multifaceted, along with imaging. What imaging is going to do is it's going to evaluate, is there any cirrhosis in the liver? Is there any HCC in the liver? And how is the liver functioning? There are tests that can evaluate if the patient has fibrosis. Historically, we used to use biopsy. We now have better evaluation diagnostics, which include things like the FibroScan and FibroSure. A FibroScan looks similar to an ultrasound, and they do that on the patient's liver. But it can result back for you as the clinician information to tell you if that patient has cirrhosis of the liver and at what stage. The FibroSure is a lab test that can do the same thing. The difference with the FibroSure is that it's collected through blood, and then you can interpret if there's cirrhosis or not. The FibroScan and the FibroSure are much more less invasive than a biopsy, which has higher risk for bleeding and the pain, and the complications from a biopsy is much more than from a FibroSure or FibroScan. So how do we treat? How do we treat? One is, if you're considering treating a patient, what we don't want to do is treat the patient inappropriately if they have cirrhosis. So although you as the primary care may not be treating your patient, it's good for you to understand that if you have a patient diagnosed with hepatitis C, you want to do the appropriate lab work, which was on the previous slide. Then you want to make sure you refer these patients for evaluation from someone who treats hepatitis C. Now, with the new treatments out, it's not always an infectious disease that can treat a patient with hepatitis C. There are many advanced practice clinicians, primary care providers who treat hepatitis C and follow those patients. But there are several different evaluation tools that we continue to use to manage and monitor those patients. If you see a patient who has been diagnosed with hepatitis C, they tell you that their provider told you they don't need treatment or they completed treatment, it is good to make notation that those patients still have to have monitoring. What type of monitoring or management or routine evaluations occur with those patients is dependent upon the level of fibrosis of the liver. Okay, and so that leads me into who should be treated. Now with the new treatments, we have the ability to treat many of our patients because they don't have the toxicity. The medicines are not as toxic as the old medicines we used to use to treat our patients. And the success rate of cure is so much higher than it used to be. If patients are considering treatment, before they can begin treatment, their labs must be done, their physical needs to be done, understanding their genotype, getting labs to determine what is their genotype, having their psychiatric evaluation perform, making sure there's no contraindications. Same thing with their medical, knowing what comorbidities they have. All of this just helps with the success of the treatment, knowing if they're going to be able to complete the treatment plan. I have included here for you some links where you can go on and look at what the treatment plans are for patients with hepatitis C. As a primary care, you may not be treating, but it is important that you do some takeaways. Some of those takeaways is one, asking the right questions to know if you need to evaluate your patient for hepatitis C. Two, if your patient labs support a diagnosis of hepatitis C, make sure you confirm that, okay? And what I mean by that, remember we talked about the HCV antibody test versus the HCV PCR test. Because one thing you don't want to do is refer your patient to the specialist off of just a positive HCV antibody test. Now, if you do that, the specialist will then have to run the PCR test, but that's a delay in treatment time because they don't have the labs that they need. But if you run that PCR test before you refer that patient, you will know, one, is it a false positive? Two, do they have any virus running around? Things like that, which would be very important. If you are unsure of either, definitely refer that patient for evaluation. But you have some treatment guidelines here that you can go on. So remember again, knowing if your patient has hepatitis C is going to be important for you. If you determine that that patient has hepatitis C, and finding out what type of hepatitis C. Remember, I showed you the slide. It can be hepatitis 1 through 6. We need to know which type they have. The third thing you want to do is do the appropriate history and physical on your patient, so that if you're referring to the specialist, they have the comprehensive information that you have acquired from your patient. 4, after you've done all of that, if your patient does see the specialist, make sure you're following up to understand what that treatment regimen looks like for your patient. If your patient has hepatitis C and has been diagnosed with cirrhosis of the liver, that is an immediate referral to specialists, because cirrhosis of the liver, the treatment will look differently. Okay, but that patient does need to be seen by specialists. If a patient presents with cirrhosis of the liver, these are the patients, they don't necessarily, they may have ascites in the belly, but they may just be talking about abdominal pain. They may look jaundiced. They may have a change in their urine. They talk about a tea-colored urine. They may have esophageal varices. They may present with these symptoms that would lean you to believe that they have hepatitis C. If that's the case, you need to refer them to specialists, and the specialist will take it from there. You just need to be able to get the copy of the consult notes and follow the treatment plan that the specialist will be doing on that patient. Okay? So again, here's some more takeaways for you related to those patients that we just discussed. And so let's now check your knowledge. Let's see where you are. Do you remember some of the information? Because I know there was a lot in there about hepatitis A, B, and C. The reason I covered A, B, and C is because those two are the most common hepatitis we will see. The D, E, you're not going to see as much. So now, you have a patient who is asymptomatic and tests positive for the hepatitis C virus. What will the provider tell the patient about managing this illness? I'll give you a few minutes to read. A, will you tell the patient rapidly filament disease ending with cirrhosis is likely? B, administering immunoglobulins helps shorten the course? C, several medications are available based on the type of hepatitis C? Or D, treatment is supportive since the infection is self-limiting? The answer is C. That's another question. Which of the following is an acute illness with jaundice, anorexia, malaise, arthralgias, an incubation period of 2 to 6 months, a chronic and acute form, and that is transmitted by perennial, sexual, and perinatal routes? Is it hepatitis A? Is it hepatitis B, hepatitis C, or hepatitis E? Phenomenal. You got it. It is hepatitis B. And remember, hepatitis B affects less than 1% of the US population, and it's much less common cause of cirrhosis. Remember, hepatitis A has symptoms of fever and jaundice, but the incubation period is 15 to 50 days and does not have a chronic form. And C, hepatitis C infection causes jaundice up to 25% of the time and can cause arthralgias, but there is no fever. The incubation period is 14 to 18 days. And up to 75% of those infected with hepatitis C will develop chronic infection. And finally, hepatitis E, it is characterized by oral fecal transmission that is associated with contaminated food and water and has an incubation period of 14 to 60 days and no chronic disease state. All right, so let's try another one. An adult patient presents to the family nurse practitioner complaining of weakness and vomiting. He gives a history of several drinks per day for the last 22 years and cirrhosis, diagnosed 6 months ago. The family nurse practitioner questions the patient about excessive bleeding. The patient reports 2 episodes of hepatitis. What emergent condition is the family nurse practitioner most concerned with? A, bleeding peptic ulcer. B, excessive nosebleeds. C, hemoptysis. Or D, esophageal varices. You got it, it's esophageal varices. So why is it esophageal varices? Esophageal varices are dilated submucosal veins that are a late sign and complication of cirrhosis because of scarring of the liver and portal hypertension. The cirrhosis would likely be advanced for varices to develop, usually in the esophagus, but also can occur in the stomach. As these varices are under high pressure, the patient can have any from the slow leak of blood to the major, life-threatening bleeding. The varices should be diagnosed by endoscopy and treated with beta blockers to lower the blood pressure. Of patients with chronic cirrhosis, approximately 50% will develop esophageal varices and will have yearly rate of bleeding from 5 to 15%. A history of heavy alcohol intake may be the cause of this patient's cirrhosis. These patients can present clinically with bleeding, spontaneous coffee grounds, or bright red blood, hypotension, and eventual shock. The other choices could be all associated with this patient. A bleeding peptic ulcer is possible, but it's not the first concern. An excessive nosebleed is possible, but the thrombocytopenia from cirrhosis and would need to be explored. Hemoptysis implies lung disease, not liver disease. So what does a patient present with when you think about the other types of cirrhosis out there? When you think about nonspecific, autoimmune, or alcoholic. Autoimmune, you can see here, those are the patients fatigue, they appear ill, they have right upper quadrant pain, they have advanced liver disease, where our alcoholic cirrhosis, encephalopathy, upper GI bleeding, and sepsis. Like the other hepatitis that we talked about in the physical exam, you want to make sure you do a comprehensive exam. But when you do their exam, the symptoms or the things you may see on your physical exam may differ. Here you can see what it may look like for someone with acute hepatitis versus chronic versus alcoholic. Your labs are very important. Diagnose no matter what type of hepatitis you're looking for. Performing your labs and your diagnostic tests such as your ultrasounds and CT is important. I would highly recommend now not a liver biopsy, however, either a FibroSure or FibroScan testing. Always remember to include your differential diagnoses. It's very important because you want to make sure that you're not missing something. And remember, just because the patient has hepatitis C or A or B does not mean they don't have something else going on. And when I mentioned in the beginning of this lecture that it was important that we think prevention, prevention, prevention along with our management. Vaccines is our major way of prevention. We know that we have hepatitis A vaccines and hepatitis B vaccines. And providing your patients with information to allow them the benefits of it is important. Knowing how to dose these vaccines and in educating your patient, it's a series of vaccinations. Hepatitis A has 2 vaccines that the patients will get. They will be 6 months apart. They will get their first vaccine and 6 months later will get their second. Whereas hepatitis B is 3 vaccines. They will get their first vaccine, 4 weeks later they will get the second vaccine, and 6 months from their first shot, they can get that last one. They do have different versions of the hepatitis B vaccine, so there is one that you only have to give two doses. The takeaway I want you to have from this is knowing what vaccine your organization carries and knowing the schedule. A way as a clinician to help you to improve vaccine completion is when your patients agree to having vaccines, schedule them to have an appointment for their return visit for their second vaccine. This way, if the patient does not come to their appointment, you can have your team reach out to that patient to inquire why they did not present. And it helps you to kind of ensure to the best of your ability that your patients complete their vaccine series and help and thus have protection. So again, when you're thinking about management for these patients, you're going to think, what type of hepatitis do they have? Is it acute or chronic? And what does treatment look like for that patient? And remember, all treatment is not medications. Some treatments may be just management or monitoring. So again, I've decided to put here just a little kind of quick cheat sheet for you. When you think about acute versus chronic, how do you want to treat it, right? Now, let's transition a little bit. I talked a little about cirrhosis of the liver, what a healthy liver looks like, and what a cirrhotic liver. Know that hepatitis C is our leading cause of cirrhosis of the liver. We also see cirrhosis of the liver for those who have alcohol-induced hepatitis. There are diverse factors that can contribute to having cirrhosis of the liver. It could be medications, as I said, the alcohol, the virus of the hepatitis C. There could be polycystic liver disease, autoimmune reasons, non-alcoholic steatohepatitis, that's another reason. Regardless of the cause, the important thing to recognize is cirrhosis of the liver is destruction of the liver. All patients are going to need that to be evaluated and treated. Okay? There are tests that can evaluate how, if the patient has cirrhosis. Earlier, I talked about the FibroScan. I told you it's like a ultrasound. Here is some more detailed information of what it looks like when you do a FibroScan on a patient evaluating the liver. Take a minute to review the chart and what the results will look like as far as understanding if your patient has cirrhosis or not when you get these readings back. What do these patients present like? We discussed that earlier. Here's just a reminder. What I hope you take away from this, sometimes your patients can present with similar symptoms for multiple disease processes. It is your responsibility to make sure you're including in your differentials the different disease processes, but doing the appropriate evaluation and assessment of your patients to determine what is the cause, and then treating and managing appropriately. As always, physical exam is very important. Make sure you're examining your patient, asking the detailed questions, collecting the data so that you can make an informed decision on what the next steps are. Also, speaking with your patient, helping them understanding what your evaluation process look like. What labs are you going to do? What diagnostics are needed? What would those labs and those diagnostics tell you? And if you do get those labs and those diagnostics back, what would be the next steps in the treatment plan so that you can prepare them for maybe needing to have further evaluation by specialists, and then how you would like to follow up with those patients as a result of even sending them to a specialist. When you think about cirrhosis of the liver, many different differentials can be considered, and we talked about that. So how do we manage some of the symptoms and side effects that these patients experience? If your patient has variceal esophageal varices, beta blockers is the standard for treating that. You put them on a beta blocker, a non-selective, that will help to prevent the bleeding. Referring them to gastroenterology so that they can do an EGD and manage and monitor those patients in collaboration with you is going to be very important. If they have ascites, these patients are going to definitely be in with the GI specialist or hepatologist. They will, if necessary, that hepatologist may do a paracentesis, restricting their sodium intake to less than 2 grams a day, monitoring their electrolytes, putting them sometime on spirolactone, it's a diuretic, and the furosemide, both, to try to help to reduce their fluid retention. Immunizations as appropriate. Immunizations which include pneumococcal vaccine, influenza, vaccine for Hep A and B if necessary. Helping these patients understand that a diagnosis of cirrhosis of the liver is a serious diagnosis. However, it can be managed and monitored, and you are a part of the team to help them do so. And so every time those patients come in to see you, you are doing an evaluation on how are they doing, what are their challenges, do they need other resources, because it can be overwhelming for patients who present with cirrhosis of the liver. So as we conclude this lecture, the takeaways from this lecture is, one, that hepatitis itself is just meaning inflammation of the liver. And depending on what hepatitis a patient has, it can lead to damage to that liver. That damage can range on a scale from 0 to 4, which can lead from a normal liver to cirrhosis of the liver. Establishing if your patient has any damage or at all is going to be important, and how to prevent further damage or how to prevent any damage is going to be important. The next thing you want to do is make sure you're doing the thorough evaluation and understanding of what type of virus do they have. Is it acute or chronic? And if you've determined that, does it need treatment or no treatment? Does it need management? And if it needs management or treatment, who's the best one to manage and treat it? Is it you, the primary care, or do you need to refer them to a specialist? And if you refer them to a specialist, you as a primary care are still responsible to be able to follow that patient, understand what's going on with that patient, because whatever they do at a specialist office can impact your care that you provide for them. Hope you enjoyed and learned something in this lecture. I would recommend that you go to your textbook, read more about hepatitis, all types of hepatitis, and then go to your guideline books. These guidelines for treatment of hepatitis are updated frequently. Understand what the latest guidelines are. And for many patients, they're not going to present, you're not going to know they have hepatitis. So understand what are the guidelines for screening patients for hepatitis A, B, and C. And then how do we educate our patients to prevent either them from getting hepatitis C, or how do we prevent them from getting damage to their liver? It was my pleasure to lecture to you, and look forward to another lecture on hepatitis in the future.